Thank you.
Thank you so much, Dr. Muhammad, for inviting me. In fact, this talk become too hard after the talks of the expert like Dr. Meza Sharia and the Indian professors. Thank you so much for inviting me. I will talk about fixation of fractured neck femur in young adults, perils and pitfalls. There is the controversies in fixation of fractured neck femur are everywhere, like timing of fixation. Shall we go at the middle of the night to push the patient for theater for open reduction or close reduction internal fixation? What we'll do, how we will fix using cannulated screws or fixed angle implants like DHS? Shall we do capsulotomy or not? The controversies are everywhere, but there is one consensus, which is the quality of reduction. The quality of reduction is the single most important factor within the surgeon's control that influences the rate of healing complications. The aim is to make the hip look like a normal hip, which is, in fact, is difficult. But in the literature, the answer for this question is not clear. What is an acceptable reduction? In fact, what is an acceptable reduction? Number one, the varus alignment is total. Sorry? Sounds clear?
Yes, clear, sir. Go ahead, sir.
Yeah. What is an acceptable reduction? The answer for this question in the literature is not clear. But there is some agreement that the varus alignment is totally not accepted. As stated by Arnold in GBJS 1984, 90 degree of varus reduction leads to 55% fixation failure. Schatzker in Journal of Orthopedic Trauma in 1988 said that any varus reduction leads to increase of fixation failure about 13-fold. Number two, less than 10 degrees of valgus alignment is unacceptable instead of varus. Less than 10 degree of angulation in the axial bone, either anterior angulation or posterior angulation, is accepted. Less than 1 millimeter superior translation of the head fragment in relation to the neck fragment is accepted. Less than 2 millimeter translation either anteriorly or posteriorly. The other important thing is that there is the inferior translation of the head fragment in relation to the neck is totally not accepted. This study is done by Gottfried in 2013, and he proposed that non-anatomical reduction of displayed subcapital neck fractures is accepted if we achieved what he called Gottfried reduction. He proposed negative and positive Patterson principles that if the head fragment is medially located relatively to the neck fragment like this, like the picture on the left side, he called it negative Patterson, which is not accepted. But if the head fragment is laterally translated relative to the neck fragment, he called it positive Patterson, which is accepted. If we look at this patient on the left-hand side, after 45 days, gradually the head fragment collapsed and subsided inferiorly until the screws cut out and the fixation failed. But if we look for the X-ray on the right-hand side, the positive Patterson, the fracture healed unevenly. How to assess the quality of reduction? There are two main parameters used to assess the quality of reduction. One invented by Drennan and Lowell's criterion, published in New England Journal of Medicine in 1966. He states that the relationship between the head and the neck is like smooth curves or lazy S, like as shown in the picture. If it is acute angled, this means there is malalignment or malreduction. The other parameter is the Gardner alignment index. If we look for the head in ideal lateral view, the trabecular pattern of the head and neck is 180 degree aligned with the shaft of the femur, and in the AV view, it is 160 degrees. The controversy regarding the timing of fixation, the study done by Peter Genodis in 2017, it was a meta-analysis assessing the timing of internal fixation of femur and neck fractures. This study failed to prove any essential association between timing of fixation of femoral neck fractures, but in relation to the non-union. but regarding the incidence of, regarding the vascular necrosis, with respect to the non-union, it indicates that a delay in fixation more than 24 hours could lead to an increase in the incidence of non-union. There is a study done by Obadhai and published in BJJ 2004 about delayed internal fixation of fractures of neck of femur in young adult, and this study showed a delay of more than 48 hours before surgery didn't influence the rate of union or the development of a vascular necrosis when compared with operation done after 48 hours. This means that the time factor, as all the concept, the patient should be pushed at the middle of the night for open reduction or closed reduction internal fixation, where the availability of the experienced team and the nursing staff and radiology technicians are not available. This is not an ideal situation because the time factor is not clear. Either to do open, the controversy regarding open reduction or closed reduction, the evidence-based update regarding open versus closed reduction meta-analysis done by Boria Gayomi showed that this systematic review includes 21 studies comparing operative versus non-operative open reduction internal fixation versus closed reduction internal fixation of femoral neck fracture in young adult less than 6 weeks from injury, at least 1 year of follow-up, and the primary outcome measure was non-union vascular necrosis and deep infections. They found that there was no evidence in support of open reduction internal fixation versus closed reduction internal fixation, and the surgical site infection may be lower with closed reduction and internal fixation. What type of implant to use for fixation of displaced fractured neck of femurs? The famous FACE trial published in 2017 in Lancet. It was a multinational study, RCT, done in 81 centers. It was level 1 evidence, well-powered study, include over 1,100 patients, comparing the results of fixation of neck of femur, either DHS versus cannulated screws. Includes patients above the age of 50 years. The primary outcome measure of this study was the hip reoperation of any cause within 24 months after intervention. They found no difference in reoperation rates for the cases who received either DHS or cannulated screws. There was higher AVN rate with DHS, but the DHS shows lower reoperation rates in certain types of fractures like basic cervical fractures, badly displaced fractured neck of femurs, and in smokers. The results, this is a study done by Frank Liborash and George Haidekovich, assessing the results of internal fixation of bowel type 3 vertical femoral neck fractures where there is shearing force along the fracture through the fracture site. They found that mechanical failure rates was higher for fracture treated with cannulated screws compared to those treated with fixed angle device like a sliding hip screw. The rate of failure was 19% for cannulated screws in comparison to the DHS, which is 8%. Cannulated screws are not recommended in bowel type 3 fractures, according to Liporach and Haidekovich, basal neck fractures, and patient with poor bone quality. This case example, the 17-year-old male, he survived an RT fall from height and his body displaced basal neck fracture that was reduced and fixed with cannulated screws, partial serrated screws, and gradually the fixation failed with sequential failure of the screws. All the screws broken. Unfortunately, I have only this X-ray, the last X-ray for the patient, but all the screws get broken, and it was revised by large head ceramic and ceramic in this young age. Because the surgeon, because we failed to revise the fixation as the head was full of metal work of the broken screws. Another example, 48-year-old male, he survived a motorcycle accident and he sustained displaced intracapsular basal neck fracture that was fixed with, this fracture was fixed with cannulated screws. I think it's acceptable reduction. But again, the same scenario, the head subsided into varus with sequential failure of the screws. The principle of the principle of cannulated screws needs The screws should be well buttressed inside the femoral neck through the proper entry. Number one, the screw entry is a courtesy of Dr. Pospula. If we choose a correct starting point of the guide wire, but the angle is not accepted, the pilot hole should be expanded with a larger drill bit to allow to readjust the guide wire inside the core created by the proper entry. Again, the screw in the femoral neck should be well buttressed, especially number one, the inferior screw should be well buttressed by the calcar of the femur to create the third point of fixation. One point at the lateral cortex, second point at the femoral at the head fragment, and the third point should be at the inferior calcar of the neck. Otherwise, the screw will toggle down. This is a study done by Lindquist in 1985. It is a biomechanical study, and it shows that the result of this study underlies the importance of achieving cortical support for the fixating screws of the femoral neck fracture. The inferior screw should be well buttressed by the calcar. The posterior screw should be buttressed by the posterior cortex of the neck, and the anterior screw should be maximum anteriorly and superiorly to achieve the three-point principle of fixation. The technique of cannulated screws. This patient has displaced the intracapsular neck fracture of femur. We put the patient in the traction table, and we achieve this reduction in slight valgus malalignment in the area view. We start firing the first wire maximally inferior, touching the inferior calcar of the neck, the calcar of the inferior cortex of the neck, and it is central in the lateral view. This is the first screw, or the first guide wire for the first screw, achieving the medial the inferior patris through the calcar. Screw number two, guide wire number 2 and number 3. The guide number 2 should be buttressed by the posterior cortex, and the anterior wire should be buttressed by the anterior cortex, and the posterior wire buttressed by the posterior cortex of the neck. This is the final results. Intraoperatively by CR, all the screws are well buttressed, and the post-operative X-ray, and this is the results after 9 months. For vertical or bowel type 3 fractures, or this shearing force through the fracture site, after reduction, we can use what's called bowel screw, which is transverse screw applied transversely across the fracture site to neutralize the shearing force, or to convert the shearing force into a compressive force. This is the reduction we achieved on table. The fracture shows shearing force. I start putting the partial threaded screw almost perpendicular to the fracture site to pull the head fragment and compress it. Then we proceed for the definitive fixation by DHS. And this is the video sent by the patient from his country. Another case, this is 48 years old male. He survived an RTA and he sustained displaced intracapsular fracture neck of femur. And this after reduction, we put the bowel screw across the fracture, and we fix it definitively by sliding hip screw. And this is the results. The fracture chip fully united. Another example of this badly displaced intracapsular fracture neck of femur in 22 years old male after an RTA. The decision here is very difficult, either to go for total hip replacement with this badly displaced fracture in this young age, which this scenario is not accepted, but the decision is difficult. We proceed for collision reduction and fix the fracture with DHS. There is a varus reduction, but the fracture at the end united. And unfortunately, the patient developed AVN, and we removed the DHS as a form of decompression or in preparation for total hip later on. The last case is this 46-year-old lady. She's working as a teacher. She has a displaced fracture neck of femur, clavicle fracture, terrible triad injury, and PCL avulsion from the tibial attachment. The advice for this patient, or the decision, was to proceed direct for total hip replacement as the fracture is comminuted and is badly displaced. This is the results after fixation after 54 months. The fracture fully united, and this is the lateral view. And the patient is walking normally without pain, no Trendelenburg gait, no limping. In conclusion, the least in femoral neck fracture is anatomical reduction. However whatever the method you achieved, it either open or closed. The implants will not differ, either cannulated screws or DHS, but there are contraindications for cannulated screws, like a patient with poor mineral density, basal neck fractures, and bowel type 3 fractures. Screws should be wide. The principles of cannulated screws necessitates the screws should be widely displaced in the femoral neck, well buttressed by the industrial surface of the neck. And lastly, the timing of fixation of fractured neck of femur still it is controversial. There is no definite conclusion, either to go at the middle of the night and to push the patient for theater, or to wait for the next coming list. Thank you.
Thank you so much, Dr. Mutwalli, for this very interesting presentation. And we have just one question for you, sir. Dr. Aydros,
yes.
Please, how to assess negative buttress?
Yeah, the negative buttress means the medial cortex of the head fragment is medial to the neck fragment. If I can go backward for the slides, it is just a step. Where the step is, either the head fragment is lateral or medial. It's as simple as that. Is it clear? This is
yes, sir. We can see the slides
coming. I'm sorry for that. Yes.
Yes.
If you look for the X-ray on the left-hand side, the medial cortex of the head is medial to the neck fragment. I will use the pointer here. Yes. This is the immediate post X-ray. This is the head fragment here. There is a step. It is minimal. But if you look here, it is quite obvious. This is the negative buttress. Regarding the positive buttress, the head fragment is intramedullary. You can say the head fragment, the medial cortex of the head is intramedullary or lateral to the neck fragment, like this. This is called positive buttress.
Yes. Yes, sir. Thank you, sir.
Thank you.
Thank you, sir, very much for your interesting presentation. And the